Hello, thank you for joining us today. We are going to wait just a couple minutes as everyone is moving from the waiting room into our main session. All right, I think we have everyone moved out of the waiting room and we um, will be getting started here momentarily. All righty. So thank you all so much for joining us today. We are going to be talking with you about the CMS Quality Payment Program's proposed rule for 2025. And so what that is going to entail, we're going to walk you through the process. We're going to walk you through the main portions of the quality payment program, those updates around the categories as well. Now, my name is Jessica Elliott, and I'm one of the quality improvement advisors here at the Regional Extension Center. I'm joined today by Jared Deason, Vance Drakeford, Tabitha Hanlon, and Vicki Harden. Just a couple quick housekeeping things before we do get started. If you have any questions today, please feel free to type those into the Q&A, the chat box on your screen. If we don't have time to answer those questions live on the webinar today, we will get back with you. So please feel free, as questions arise, please drop those into the chat for us. Now, and again, as I mentioned a few moments ago, we're going to talk to you about some of CMS's proposed updates to traditional MIPS as well as MIPS Value Pathways. We're going to talk about that potential sunset date for traditional MIPS as well, too. We're also going to talk a little bit about the APP track or the APM performance pathway, some updates to APMs and Medicare Shared Savings as well. Then we're going to briefly touch on a couple of the impacts that we have noted for other areas that sit within the physician fee schedule, but not within QPP itself. And then finally, we're going to talk to you about our top 10 impacts from this proposed rulemaking. So I just wanted to share the citation here. We have some links regarding if you want to go and look in and pull up the actual Federal Register itself and the proposed rule within that. We also have a couple different fact sheets as well that you're welcome to access. At the bottom of the screen, you're going to see how to submit comments. So we're going to mention this probably several times during this webinar, but we highly encourage you, and actually CMS actually strongly encourages our clinicians, our practices, systems, professional organizations to comment on any of the proposed changes within this document. This is CMS's only way of getting that clinical implementation perspective. That is their formal process, and this is the only process they have. If you have challenges around obtaining your data, challenges with vendors, challenges with implementing and integrating some of these processes, it's really important for you to be able to provide feedback to them, because that really does help shape and drive the program itself. So now let's talk about some of the updates to the traditional MIPS and the MVP track of the program. So again, you all are pretty familiar with how this is set up. We have our MIPS track, which is traditional MIPS. And that is intended to be sunsetting here within the next few years. Eventually, MIPS Value Pathways will be the way that if you are not a part of an ACO in some type of an alternative payment model, you would be participating in MIPS through the MVP track. And so that is something to definitely consider, this trajectory that CMS has set for this program. Now, some of these updates around eligibility, weighting, everything like that, CMS has actually kept the category weights. They have maintained that as a part of the macro legislation. So we are at the final category weights that has been approved and set forth by Congress. So we don't anticipate really seeing any of those shift unless through a congressional act. CMS has also chosen not to increase or decrease the low volume threshold for eligibility for our clinicians. So everything is going to stay as it has been to being required or eligible, as CMS likes to call it, for the program. One other thing that they have maintained, the automatic promoting interoperability reweighting for special practices. So if you are deemed a small practice or HIPSA or ambulatory surgical center, those types of things, you would be able to do that automatic reweighting for PI. However, they have removed all clinician types of reweighting for PI. So the last holdout was our clinical social workers, and those are now, they do not get an automatic PI reweighting unless they have a special status designation. They have also not approved any additional eligible clinician types. So no further expansions are proposed for calendar year 2025. CMS has also set the payment adjustment for 2025, that threshold that you have to hit, at 75 points. So they have maintained that from the last couple final rules. And so they are carrying that over into 2025. CMS is using the methodology of the mean of 3 previous historical average scores. And so they right now are looking at 17, 18, and 19. And that's what gets us that 75 points. We do anticipate that shifting, and they're going to look at some of the next 3 post-COVID years and will likely generate a threshold based on that, which will likely increase. But again, we don't have anything proposed or finalized beyond 2025 as far as that threshold goes. A couple other things that I wanted to just highlight is that CMS has also made some updates to measure removal criteria. Again, this is something that CMS has done in the past. However, they haven't really had some formal rules and regulations around it. And this also affects all 4 performance categories. So CMS just solidified some language and put in some guardrails as far as removing measures from the program. CMS also made some updates to the final score calculations, and specifically what applies to that are some additional flexibilities for category reweighting. So rather than through the EUC process, there is an opportunity that if you as a clinician or a provider are unable to access your data, specifically if your data is being submitted by a third party and they are unable to do that submission for you, whether there was a technical issue or whether they are just no longer certified as that registry, and so they weren't able to do your submission, it will actually retro back to 2024. So in the 2025 performance year, you will be able to actually apply for a category reweighting if you were not able to submit data due to that type of an error. So that is something to consider and to think about. If you have questions about that, do reach out to your REC advisor. We're more than happy to talk you through that. And then finally, CMS did propose, I should say, to kind of clean up some of the data submission requirements around all 4 of the categories, just like they did with removal factors. So an example of this is with the promoting interoperability category. You must have start and end dates and all required elements, including those attestation questions, and submit numerator and denominators for all the measures that are required for that. Sometimes there would be some unintentional PI submissions. Things would get rolled up into a QRDA3, and there would be PI data in there, and it would trigger if somebody had an automatic reweight. So this is something, or they applied for a hardship exception. And so it would calculate that, it would trigger that score to be calculated. So this is a way to help prevent that error from occurring. CMS has also cleaned up and clarified some language around multiple data submissions. So typically it's been the last the last file that was submitted for a category, regardless of who submitted it, would be what was scored. Now what CMS is proposing is to really look at the submitter type, who is sending it, whether it's internally within an organization or whether it's from a third party. And so that is going to impact and influence which submission they score, whether it's they're going to score all of them and they'll take the best score, or they will still retain for certain categories. They will retain the most recent score. So now with that, we are going to start talking about the individual categories, and we'll start with quality. So let's talk about some of the measure updates. CMS does like to update, remove measures, add measures to the quality category. Tabitha, do you mind to talk to us a little bit about some of your takeaways from this year's proposal?
Sure. So first, for data completeness, that's going to stay at 75% through performance year 2028. So we have a few years where we're not going to have to worry about anything changing for that data completeness threshold. There were 9 new measures that were proposed for addition to the quality category. And that sounds great, but all 9 were MIPS CQM measures. So if you don't utilize some type of CMS approved registry, those are not going to be available for participants to report. On the flip side of that, there were 11 quality measures that were proposed for removal. All were MIPS CQMs except one. That was an ECQM, and that was appropriate use of DEXA scans in women under age 65 years. So the last thing I'll mention is around an administrative claims measure, and that is going to be the risk standardized acute cardiovascular related hospital admission rates for patients with heart failure, which is a mouthful. But that was added in performance year 2024, and it was originally listed as being able to be scored for individual eligible clinicians. CMS has realized that that measure was only tested at the group, virtual group, and subgroup level, and not at the individual level. So they're proposing to update the language to account for that. And if finalized, that would retro back to anybody or any individual clinicians that were scored on that measure in performance year 2023 and 2024.
Okay, thank you, Tabitha. Something else that CMS is proposing is to amend its policy around topped-out benchmarks, and we're starting to see more and more measures hitting that status. Can you talk to us a little bit about what topped-out means, and then what CMS is proposing, and how this could potentially impact our clinicians and practices?
Right. So a measure is considered topped out when the measure's performance is so high consistently that it's determined meaningful improvement can no longer be made. So while a measure is listed as topped out, the maximum points awarded for that measure is going to drop from your usual 10 points down to 7 points. And it makes those measures a little less desirable to choose. I mean, if you're going to choose a measure, you want the full bang for your buck. So it makes it just a little bit less desirable for choosing that measure. And generally, a measure that's been deemed as topped out for 2 consecutive years is removed from the inventory for quality measures. So right now, there's just that single benchmarking methodology for all topped out measures. CMS is proposing to use a flat benchmarking methodology instead. In areas that have limited development in measures, and that's specifically specialty measure sets and MVPs. So with that proposal, it would remove that 7-point cap on the topped out measures, allowing those to be reported for those specialty measure sets and MVPs, and potentially be awarded the full 10 points, depending on performance, of course. And one thing to keep in mind with this, it would not be across the board for all topped out measures. CMS would still retain discretion on which measures they applied this policy to, but it's a starting point toward being able to improve utilization of MVPs as a method of reporting.
Yeah, I think I appreciate that flexibility is going in there, at least for those specialty measures, to be able to help clinicians, right?
Mm-hmm.
So shifting gears just a little bit, we're seeing a lot of MIPS CQMs being added into the program, but I think sometimes this could, inadvertently place a significant financial burden on practices, especially those who are already utilizing an EHR, Now, some of these EHRs can report these types of measures, but others can't. And so that would require, really a costly external registry connection. And, we're seeing this trend really in contrast to the slower growth of ECQM approvals for the quality category. Tabitha, can you talk to us a little bit about some of the context behind the growing of MIPS CQMs?
I think it's really in preparation for sunsetting of traditional MIPS and their goal to have at least 80% of Medicare beneficiaries in some type of accountable care relationship. They're slowly expanding the list of specialty measure sets and the availability of MVPs for different specialties. Both of those options are kind of a more structured process of measure selection. And even for those in primary care, not just specialty, it's just a more structured process. The outcome with that is, the eventual transition to one of those other reporting methods and continuation of realizing that 2030 goal of having more folks report under the APP.
So, looking through this proposal, what sort of trends have you been able to identify that CMS is sort of forecasting in the future for this particular category?
Right. So, we've talked about reliance on those QCDRs and qualified registries. And with that continued push for registry measures and the lack of development in those ECQMs, it just continues to get more and more difficult for clinicians to find those ECQM measures that are meaningful to the work that they're doing. So for clinicians in larger organizations, such as like hospital affiliation or hospital affiliated clinics or multi-clinic groups, the affordability of utilizing a registry might be more within grasp for those folks, but then you have to think of, that they have a lot more clinicians on board, and that's also going to drive up the cost of being able to afford those registries. For those in smaller private practices, it's going to be much harder to afford the cost burden of having a registry. Some EHRs, like you mentioned, Jess, are approved registries, and it's great for those folks. But then the rest have to find a way of meeting the reporting requirements and not break the bank at the same time. So joining an ACO would be a possible answer. So again, there's that nudge toward reporting for the APP or through the APP.
Yeah, I do find it interesting that CMS is incentivizing ACOs to continue EHR reporting, and we're seeing from the MVP perspective that there's a push to move to registry over ECQM. So definitely interesting to see how that's going to trend in future proposals and final rules for sure.
Yes.
So thank you, Tabitha.
You're welcome.
So now, thank you. So we're going to move on to the promoting interoperability category. And Vicki, we did not see a lot of significant changes to the PI objectives proposed for 25, but CMS has proposed some updates to the language around the minimum criteria for PI submissions that we talked about earlier. But I do also have a couple questions for you. Is there anything that we need to keep on our radar for how they're going to score PI submissions? And then also, have we seen updates on the ONC HIT CERT criteria or the CERT ID? Could you talk with us a little bit about that?
Sure. And you're absolutely right. There wasn't any major updates to the PI category for this proposed rule, but this rule reflected a lot of language from the ONC. And so I just want to kind of just throw out a couple of language updates for this proposed rule. One of them, Jess did touch on just a little bit about data submission for 2025. CMS is proposing not to consider those incomplete data submissions, and they're going to require minimum criteria, which will include your performance data for each measure, of course, required attestation statements, your EHR certification ID, start date and end date, and then, of course, your CERT ID. And then another update worth mentioning that our clients would be familiar with, and this could impact the HIT vendor, would be For 2025, ONC has adopted the certification criterion of decision support interventions, which will replace clinical decision support. So those are two of our those were the two common, not common, but the two language updates that we saw that was passed down from ONC.
Thank you so much, Vicki. And kind of transitioning over to other things that were found in other rules and proposals, not the QPP, that pertain to the PI category. We saw that the approval of the disincentives for information blocking, that was finalized outside of the physician fee schedule proposal. What impacts do you think this is going to have to clinicians in the context of the quality payment program if they are found to be information blocking by the ONC?
Yeah, and so ONC finalized the rule that implements those appropriate disincentives for providers who have committed information blocking. This means that a provider who has committed information blocking will no longer be a meaningful user and will receive a 0 score in the MIPS promoting interoperability performance category. And also, if you have submitted a PI score for previous for 2023 and you're found information blocking, you could actually receive a negative payment adjustment on that one. So that's pretty substantial if a provider is found violating that information blocking rule.
Absolutely. Yeah, that's gonna impact your final score and your payment adjustment for whatever year that is deemed as information blocking. So definitely a big impact to call out. Another thing that we saw from the ONC is that they are going to be updating the SAFER guides. So can you talk to us a little bit about that and when we can expect those updated versions?
Yeah, there wasn't a whole lot of information in this rule about what those SAFER guides will look like coming down in 2025, but they did talk to us about, or the rule did kind of state that the updated versions of the SAFER guides would be available as early as calendar year 2025. So early 2025, we're not for sure again what those are going to look like. Those will be required in 2026 if this is finalized. But we recommend being on the lookout for the updated versions of the SAFER guides and start reviewing them as soon as they become available.
So we're seeing things from CMS, the ONC, and Health and Human Services in general, and all of it is pointing to promoting interoperability and really finding ways to increase that piece of interoperability, right? That is the key. And so we're seeing some more innovation around FHIR and API connectivity. This and other standards that they're working on is really aimed to help simplify that data exchange between systems and, create more of a common programming standard or a common language between these different types of platforms so that you can more readily share information back and forth. Long term, we really hope that this is going to help reduce some of the connectivity costs from our developers. When you're trying to connect and share information with other health information exchanges, like we have this wonderful platform KHI here in the state that is completely free, but there are costs associated with developers to be able to connect to that. So Vicki, what are some other HIE trends that you are seeing come into play?
So some future forecasted items for coming down from CMS. One is, of course, starting in 2027, eligible clinicians, hospitals, and critical access hospitals will be required to attest to submitting at least one electronic prior authorization request per year for medical items or services, and that's excluding drugs. This will be a condition for being considered a meaningful user of the electronic health record. So that's important. That's coming in 2027. That will be an additional measure for your promoting interoperability category. Also, starting in 2026, a certified health IT vendor will be required to support internet-based methods for a patient to request privacy restriction. So those are just two of several forecasted policies or rules coming down the pike for the promoting interoperability.
And we also have another one that's from outside of the physician fee schedule, that's from the Health and Human Services around creating cybersecurity performance goals. Can you talk to us a little bit about those, Vicki?
So cybersecurity performance goals are a voluntary, and I just want to really strongly speak this word, voluntary is not required, subset of cybersecurity practices, and they're divided into categories. And you're going to have your essential category, you're going to have your enhanced category. Your essential goals will focus on the areas such as email security, strong encryption, incident planning, and preparedness, while your enhanced goals will focus on your third-party vulnerability disclosures, any cybersecurity testing, and any configuration management. The purpose of these goals are designed to ensure that extra layer of protection at different stages of an attack. And they are strongly promoted through the security risk analysis that you're already completing annually, and then your safer guide measures.
Thank you, Vicki. And I have one final question for you around this category. See on the screen, we have highlighted live by 2025. Can you tell us what we mean by that?
Yes. So for this year and previous years, if a practice has attested to option 1, pre-production and validation level phase, and usually that means there is a K-high addendum in place somewhere, it may have been signed a year ago, 2 years ago, but there is a addendum in place. Those practices for 2025 will have to attest for option 2, which is the validated data production phase. Practices are only limited 1 year now for option 1. So it's really important to kind of get that process moving to get into that live phase. So you must meet active engagement for phase 2. You must complete testing and validation of electronic submissions and are electronically submitting production data to the PHA or CDR. So you may really want, this may be a really good time to reach out to your KHI representative and say, hey, what do we need to do to be live by 2025?
Thank you. Yeah, it's a good reminder to have that on our radar. Things get passed in previous years, and so it's always good to have that refresher. If you do have questions about that, please don't hesitate to reach out to one of us, your advisor here at the REC. We're happy to help talk you through option 1 or option 2. Now, we're finally going to get to improvement activities, right? They have their moment in the sun. Jared, do you mind to talk with us about what CMS is proposing for this upcoming year?
Sure. CMS is proposing some major changes within the improvement activities category. The first big proposal is to eliminate activity weighting starting in program year 2025. Along with that, CMS is also proposing to reduce the number of activities eligible clinicians will need to participate in. So that means that eligible clinicians within traditional MIPS will just need to complete 2 activities, and those that participate in small practice or through an MVP will just need to complete 1 activity.
All righty. So it does sound like that's going to be a little bit easier, less of a lift for our practices. One thing that we did notice, there are some very commonly used improvement activities, especially here in the state, that CMS is proposing for removal. Can you talk to us a little bit about the CMS's rationale for removing some of these?
Sure. So CMS went ahead and codified some removal factors on how they plan to remove measures. The big one here is that 24/7 access to patient's medical record. This is a measure that we here at the REC have typically suggested to use, as it not only improves access to clinicians, but it's really easy to grab your documentation of completion of that activity. In this notice for proposed rulemaking, as I stated, CMS has codified 7 removal factors for improvement activities. CMS feels that this specific measure meets that obsolete factor. If this activity or others on this list are ones that your practices are using, reach out to your advisor and see about other activities that are viable to pivot to. As Jess stated at the beginning, you can also submit your comments to CMS about leaving activities on the inventory that are important to you.
Alrighty, so Jared, having read this part of the proposal, what's your initial take on a lot of these changes for our clinicians and practices?
Yeah, so Jess, with the removal of activity weights, reducing the number of activities needed, and establishing those removal factors, the writing's kind of on the wall that CMS is going to be doing a large overhaul of the improvement activities category. To me, it indicates that we should expect more and more of activities to be removed, and the activities kept within that inventory is what CMS is going to deem as clinically relevant and a high priority. I think there will be a pretty limited number of activities in the coming years, so we should be on the watch for that.
So as far as future trends, you're thinking kind of limited choices?
I do.
Okay. Well, that is good to know. So we'll keep an eye out on what they end up finalizing for improvement activities. Now we are going to transition to our final category, cost. And so cost, just like with quality and improvement activities, we're seeing measures being added and modified. There are actually 6 new cost measures that are proposed for 25, and we'll talk about those on the next slide. My question is for you, Vance. How do you think these newly proposed measures to this cost measure inventory are going to affect our practices?
Well, no measures were removed this year, so there are now actually 35 cost measures that clinicians and groups can be scored on. This may mean you could be scored on additional measures in fiscal year 25 if they're finalized. And if you think that any of these measures or services that your clinicians offer, then it's probably going to be really helpful to look at the measure specs for those measures if and when they are released and learn the specifics about them. Our team here at the REC are always here to help look at your previous cost performance feedback for the category and then discuss any of the cost measure specs with you.
Thank you, Vance. So with these new cost measures that are being introduced, what do you all think about? What do you think about sort of the upcoming choices between reporting for MVPs and the APP? Do you think this transition is going to be smooth for our specialty-based clinicians, or do you think they're going to face challenges with this?
Well, you can see the new measures being proposed to be added. The current MVPs don't really have a large selection of cost measures for a lot of specialties. So CMS is addressing more measures or adding more measures and trying to be more inclusive of those specialties as the QPP program kind of progresses. Now, if the measures are finalized, there will be better representation for diagnosis and specialties. So I think CMS is trying to make it equitable for both primary care and specialist, but it's still going to take a lot of time. So I feel like these specialties, or at least a lot of the specialties, especially those that aren't still as represented, will need to choose MVPs that don't fully represent the work that they're doing. So, or they're going to need to consider joining an APM or an ACO and report through the APP.
Yeah, because I mean, essentially, cost measures are that springboard for MVP development too, right?
Yes.
So overall, where are you seeing specialists kind of fit into cost for the QPP? I know CMS is seeking a lot of comment from clinicians, specifically how they feel that their specialists within their organization can best report. My last question for you is about the benchmarking methodology, though. Can you talk to us a little bit about how do you think that is going to impact our cost measure scores?
Well, okay. So CMS is still proposing to use performance period benchmarking, but beginning with calendar year 2026, They're thinking that the methodology that you're seeing here is going to align more closely with the quality category. So changing the benchmarking from using flat benchmarks to looking at a median performance is going to align more with the way that benchmarking is performed, like I said, with quality. So the median is that exact middle value in a data set. And to really have more favorable scoring, clinicians and or groups are going to need to have lower cost than that national median to achieve the higher score. And then clinicians or groups with higher cost and that are further away from that median is going to result in having a lower cost score.
No, I think that's I'm interested to see how this is gonna to shape up, to see if we can have more people getting better points in that cost category, because it is so important.
Right. And hopefully that new benchmarking in the next couple of years will be helpful for them.
Yeah, hope so. Alrighty, so we're gonna switch gears and we're gonna talk about MIPS Value Pathways. One thing I did want to highlight here is that CMS is requesting comment on a potential sunset of traditional MIPS in 2029. We've seen a lot of different dates mentioned across multiple proposals. Nothing has been officially proposed for 29. CMS does want practices, organizations, everyone to reach out and to give their feedback on this. You know, are they having challenges with being able to aggregate their data? Are they having issues being able to have vendors that support MVP submissions? Are you challenged by measures and how to divide into subgroups? All of these different things CMS is really soliciting feedback for. So that's something to keep in mind. So Tabitha, let's talk a little bit about MVPs. Can you talk to us about some of the highlights that CMS has proposed for this track of the program?
Yes. So CMS is proposing to modify all 16 MVPs that are currently included. And that's going to include consolidating 2 of the previously finalized neurology-focused MVPs into one single MVP. So there's that. There's also 6 new MVPs that are being proposed for addition in 2025. And we'll look at those here in just a minute on one of the next slides. There's also going to be some changes proposed around the registration process for MVPs. So previously, when you registered for an MVP, you kind of chose the MVP that you wanted to select, and then you would select the population health measure and an outcome-based administrative claims measure that was included in that MVP's foundational layer. So CMS is proposing that for performance year 2023 and 2024, that participants are going to be scored on the population health measure that they chose when they registered. So this isn't going to be like a retroactive change and go back and affect other performance years. But for 2025 and beyond, they're proposing that the high scoring population health measure that's included in that MVP's foundational layer is what's going to be used instead. So, if case minimums aren't met or there's no benchmark for that administrative claims measure, of course, it's going to be excluded from the total points, but otherwise the high scoring one would be the one that would be included in your score. The outcome-based administrative claims measure would still be chosen during the MVP registration. And last, CMS is proposing to modify the policy around cost measure scoring and subgroup cost scoring when reporting MVPs to ensure that there's alignment between MVPs and traditional MIPS.
Yeah, I think it's interesting how they are having everybody look at those foundational measures and being assessed on them. I think, from what I could glean from it, is really trying to keep practices from sort of gaming the system and trying to select a measure that they know they won't hit the threshold for to be scored on it. Yes. So I think this is maybe their workaround for that, right?
Yes.
So we've seen a lot of ink in this proposal about specialty reporting. We've talked about it several times already. Can you talk to us a little bit about what CMS is looking at as far as options for specialists to participate in MVPs?
Right. So Vance mentioned the expansion of the cost measure inventory, and how the basis of MVPs is kind of countered off of those cost measures. I think it's a great time to kind of pull in subgroups to that conversation. So subgroups are going to be required for performance year 2026 from reporting MVPs. And that's if you're considered a multi-specialty practice. So to go along with that, CMS is also proposing placing limits on subgroup composition and the number of clinicians that can be a part of an MVP depending on the size of their 10. So for example, a 10 with less than 100 clinicians would have a size, the size of their subgroup limited to 50 clinicians. And that's just an example, but the reasoning behind that change is going to be to make sure that subgroup composition is more meaningful, and the care that the clinicians within that are providing, or the care that they're providing, is mirrored in the MVP that they chose. And it's going to kind of help to streamline the reporting process and improve relevance of the comparisons that they make among those specialties regarding the data. So I also want to mention that subgroups are still going to be able to continue to submit their affiliate groups PI for 2025 and beyond. As of right now, anyway. They would not have to break that out specifically for the clinicians reporting within the subgroup. They could just report the group's PI. And CMS is also considering removing small multi-specialty practices from the subgroup mandate. So those practices with 15 or less clinicians. And that would help to soften the transition of reporting MVPs for those smaller practices. And it would ease some of the burden of having to split that small practice into smaller groups in order to report subgroups for an MVP. So it would just help to ease the transition and pull some of those small practices in.
I think that's a fantastic thing that they are putting forward for this. Anything that we can do to help it make it easier for our smaller practices to participate. So just wanted to share briefly the new MVPs that are proposed, ranging from dermatology, GI, pulmonology, optometry, urology, and then there's a general surgical MVP that is proposed as well. So now we're going to shift and talk to some of the different things that we've been seeing, just sort of the writing on the walls for MIPS Value Pathways. So I think it's just important for us to have some context of how this program may shift. I do think that we're going to see a lot more emphasis on specialty representation. I also think, like as Tabitha mentioned, subgroup reporting as well. So Tabitha, do you want to talk to us a little bit about what your thoughts are?
Sure. So CMS plans to determine clinician specialties primarily based on Part B claims data. And that's including the care types, billing procedures, and volumes of those procedures billed. So the data would be used to assign specialties starting in performance year 2026. And while the PACOS taxonomy data would be considered, it's going to have a lesser role as far as determining the specialty of those clinicians within the MVP.
And I think, them pairing it with claims data, it's actually good. I think it's really going to help give a truer indication of how you're going to need to form your subgroup. And I anticipate they're going to continue to put more guardrails on that subgroup formation. But I think it's going to impact, in particular, your advanced practice providers, right? Typically, they're lumped in as primary care in PACOS, but they might actually be delivering more specialty type care services, right?
Right. And that's where the volume of services and the procedures billed would come into play when CMS is assigning that specialty. So if a clinician practices in a group that's offering multiple specialties, and we'll just say dermatology and urology, and CMS is going to assign the specialty based on their primary focus. So a clinician who performs many dermatology procedures and they have a higher volume of dermatology patients, even if they see some urology follow-ups in the mix of that, most likely they're going to be categorized as having a specialty of dermatology, where that volume of the services that they are billing falls under that umbrella. And the end result of that is going to be to have more relevant data when they're comparing. They want it to be more of an apples to apples comparison rather than having all of these different clinicians lumped into the same group.
You know, another thing we've talked about a lot is cost measures, right? And how MVPs are built around those. You know, I think there's a good example in this NPRM where CMS, I think, really has kind of communicated for the first time that, you know, like if you're looking at the surgical specialties, they do not intend to have a cost measure built around every type of subspecialty in that surgical area. So they are talking about some different things that they're proposing, you know, so that that surgical care would almost be like a universal surgical MVP that you participate in. They've also talked about having some type of an all-inclusive specialist MVP. So sort of a catch-all for those who don't have a cost measure that's directly applicable to to build an MVP around. What are your thoughts on that, Tab?
Well, we know when it comes to like the creation of measures and legislation, the key factor in that is time. It's not a fast process. I feel that, you know, them having like all-inclusive MVPs and things like that, it's more of a temporary Band-Aid than a long-term solution. And if you're having such a broad approach, is that really much different than traditional MIPS? You know, if it's a one-size-fits-most approach, there's going to be a lot of specialties that are represented in that combined data, and it's going to muddy the waters when it comes to that cleaner data that they were pursuing, like the apples-to-apples reference that I made just a few minutes ago. And it seems to kind of defeat the purpose of MVPs if they kind of stick with that mindset.
Yeah, no, I completely agree with you there.
Yeah. And CMS does ask for guidance from stakeholders in the creation of MVPs. So there's specialties that aren't necessarily represented right now in the current MVP inventory. And that's just an opportunity to get involved. And it's been something that Jared's mentioned, and Jess, that you've mentioned, and Vicki also mentioned earlier in the webinar. When CMS is requesting comment on those different topics, it's really an opportunity to lobby for the things that are beneficial to you as a participant in the program, or to signal to CMS some negative effect that it's going to place more burden on clinicians, and that could eventually trickle down to the patients that you're caring for. So it's just a call to arms, just to kind of put your opinion in and how things are going to affect you long term.
Exactly. They might not listen to what they might not enact what you say, but they do actually read it and they comment on it in the final rule, in fact.
Yeah.
So it's nice to know that you're at least being heard as far as that goes. All righty. So I know we have a jam-packed webinar for you today. We still have a couple things we want to talk about. So we are probably going to go a little bit over an hour. We will, if you do have to drop off, we will be sending out a copy of this recording so you can always catch up as well too. Just wanted to give you a heads up on that. So now we're going to talk about Medicare Shared Savings. We're going to talk about some updates to the APP, as well as some changes for advanced alternative payment models. And actually, that's what we're going to start with as well. Jared, you and I have spent a lot of time digging into the APMs and the APP pathway. In July of this year, Congress actually finalized the Consolidated Appropriations Act of 24 that actually changed some of their timelines and mandates within MACRA. This actually caused some retroactive updates. Do you mind to talk through those for us?
Yeah, certainly. So yeah, as Jess said, we've got to look back at 2024 here first. So with the Consolidated Appropriations Act, it extended APM incentive payment an additional year, and this went into effect on July 18th. And it extends the incentive bonus of lump sum adjustments of the 1.88%. This means APM QPs will get both that 1.88% lump sum adjustment as well as the 0.75 adjustment for all covered services. For 2025, there is no lump sum adjustment at the moment. That could change with some legislative updates. So there, you will just receive that 0.5% adjustment for your covered services in 2025. The conversion factor is anticipated to go up in the future as the program progresses, and further lump sums can be added in future legislation. Looking at the QP thresholds for 2025 to receive full QP status, 75% of your payments and 50% of your patients will need to be funneled through that APM. This is increasing from the current QP determination of 50% payments and 35% patients, which you can see will now be that new partial QP status for 2025.
And then also too, we didn't really have any PI category updates. They do still want to move forward with eligible clinicians, QPs, and partial QPs who are part of an ACO, that they also report that MIPS PI category so that it can then be aggregated. Something they added was a complex patient adjustment. This is a bonus essentially for those ACOs and APMs who are participating in the QPP under the APP, or even as traditional MIPS or MVPs, if they submit a measure electronically. This does not apply to non-ACO or advanced APM participants. But if you are a part of that, you can earn one additional achievement point per ECQM that you submit. And then also CMS has made some updates to the beneficiary assignments. So they're actually shifting away from looking at E&M billing determination to look to see who to attribute to the ACO. They're actually changing that, and they are looking more at the covered professional services. So they're going to be looking at that volume to help determine sort of your denominator, so to speak, of who should be included in your ACO. That makes a difference as far as, that minimum that you have to maintain for Medicare Shared Savings. You have to have those 5,000 beneficiaries. So that's another way, one, that you can get those beneficiaries. And number two, that it can also bring in those visits that are provided by a specialist, because that's another focus that CMS is really trying to do. Again, we're talking about specialists. They are trying to figure out a way to get specialists either through the MVPs or to transition to an ACO. And historically, ACOs have been very primary care based, and they haven't done a lot of recruitment around that specialty care. So this is another way to try to pull those visits and those patients associated with specialty into that larger ACO group. So one other thing that's pretty significant is, in addition to the APP, is they have created another measure set. So you still have retained that APP core set. They have added an APP plus set. This is mandatory if you are a part of a Medicare Shared Savings ACO. If you are a non-Medicare Shared Savings, meaning you're not part of MSSP, any of the tracks A through enhanced, you would just continue to report that core measure set of those 6 measures. You could choose to do those additional measures, but it's optional. If you are in MSSP, you have to do those, and those are going to be phased in starting with 2025 breast and colorectal cancer screening, and that phase in is going to last until 2028. And then finally, a couple other things that they are putting forward, especially requesting information on around shared savings, is increasing for Medicare Shared Savings or MSSP ACOs, looking at adding more risk as well as more reward to both the tracks C through enhanced. So again, this is something that they are looking at, as well as the enhanced track. So also, they are looking at, similar to our advanced investment payments for new ACOs that are coming down the pike, they are looking at doing some type of a prepaid savings for existing ACOs. So you have to be in track C, D, E, or enhanced that would be able to take advantage of this. And it is a quarterly payment that is paid out over the term, similar to those advanced investment payments, as well as you have to pay them back. You're going to be paying them back from either your future shared savings, and they'll take it, every couple of years from that, or if you do not have shared savings, you are going to have to repay it directly from your ACO. Now, this funding, and the reason why they're prepaying it, is to really help with ACO infrastructure. It can be used for staffing, it can be used for technology, it can be used directly for patients, helping to mitigate some of those social drivers of health, getting them transportation and access, food vouchers, things like that. CMS is also proposing to adjust that 5,000 beneficiary minimum. You have to have it still at the beginning of your agreement period, but it can dip down below 5,000 during that agreement period. And then, of course, when you'd resign, you have to be back up to 5,000. CMS is also proposing some updates to the health equity benchmark. This was new from last year. And so it's primarily been the regional adjustment factor, as well as looking at any prior savings adjustment to be able to get a bonus added on to your quality performance standard. Because remember, if that quality performance standard is what allows you as a shared savings participant to be able to participate and get your full volume of shared savings that you've earned. So they're also adding a third component of it, which is looking at the percentage, that ratio of Medicare Part D patients who are in a low income subsidy, or that they are dual eligible for Medicare and Medicaid. So really what this is to do is to really try to help incentivize and bolster the scores, the quality scores of rural and underserved practices, to help incentivize them to join an ACO. And again, that's really that push that we're seeing. They want to see more rural-based healthcare systems participate in ACOs, along with pulling in specialists as well. They're also talking about doing some separate specialist requirements. So maybe if you're a part of an ACO, you wouldn't submit that measure, the APP Plus or the APP measure set, but you would participate in APM. And so they're talking about all different sorts of ways that you could navigate this program and have meaningful measures to report on. Again, we continue to see an emphasis on those larger health systems to transition to APMs as well. So with that, we are going to talk about some of the other changes that we thought were important just to do a quick shout out to across the physician fee schedule, but maybe outside of the realm of the quality payment. I'm going to hand that over to Vance and Jared, who are going to talk us through a couple of these areas.
Yeah, so I'll start off here with telehealth. So we have to remember that telehealth policy is not singularly controlled by CMS. Much of the waivers put into place during the pandemic were dictated by Congress and federal legislation. As such, Congress will have to act sooner than later to avoid many of the waivers ending with the calendar year and December. So CMS is attempting to mitigate any potential impacts should Congress not act to extend the waivers by December 31st. CMS has the opportunity to pass some actions, but the waivers and some specifics, Congress has control over telehealth through federal statute. So what CMS is proposing in this rule is to update the definition of interactive communication to allow audio only for any services delivered via telehealth. They're proposing to add 2 new G codes to be added to the permanent list regarding counseling for HIV to be provided by physician or qualified health professionals. CMS is also proposing to delay the 1-year prior in-person visit requirement that's in place for FQHCs and RHCs when providing any mental health via telecommunication technologies. Jess, if you want to push it to the next slide.
Thank you.
You're welcome.
Okay, I'll talk about the CRC screening. So in the physician fee schedule, outside of that quality payment program like Jess was talking about, things about some billing that could affect your billing regarding colorectal cancer screening. They're removing the coverage for the barium enema procedure for colorectal cancer screening. They're adding coverage for the CT colonography procedure. And now they're going to include a blood-based biomarker test along with that non-invasive stool-based test in that definition of complete CRC screening. So those three things are being done for the CRC screening. Now, if we talk about on the next slide here, the Medicare Diabetes Prevention Program. So the things that they're doing here, not a lot of huge changes, but just here, they're aligning some things with those standards for 2024. They're updating some terms and definitions, removing a term. They are now going to allow a to-date stamp photo or a video recording for self-reported weight during distance learning sessions. So those will now be accepted. As far as payments for the Medicare Diabetes Prevention Program, they are removing that bridge payment, that G code of 9880, and then they are also having that same day makeup session is going to require that CPT modifier 79 on your claims in order to get credit for that.
So the big notable change that I saw around behavioral health that CMS is proposing is to extend payments to freestanding substance use disorder treatment facilities, crisis stabilization units, and urgent care centers, and CCBHCs for intensive outpatient program services. So this would really help out those of the clinics that are working with substance use disorders.
Alrighty, thank you all so much. Now we're going to go over some highlights. So again, CMS has specifically called out within the QPP portion some RFIs or requests for information. Vicki, do you want to, excuse me there. Vicki, do you want to talk to us a little bit about, again, just reiterate that sunset date for traditional MIPS?
And we've talked about this a couple times so far in this webinar, but it doesn't, believe me, it doesn't hurt to talk about it more and more and more just to prepare and plan for 2029. But so in this proposed rule, as in other previous rules, CMS discusses the sunsetting of traditional MIPS. And for this specific proposed rule, they gave a targeted year of 2029. So some things you need to probably think about leading up to this target year is, are your clinicians ready to report MVPs? Are there applicable MVPs available for your clinicians? You want to review that MVP inventory list now and start reviewing that and start trying to see which ones align better with your practice, and establishing the subgroup criteria, which includes considerations for multi-special small practices.
I think those are some great next steps that we can try to take, just looking at what they're pushing forward so far. One thing that we have also talked about too with quality is we're seeing they're wanting to do a request for patient-reported outcome measures. We've seen a couple of these already finalized, but CMS is really wanting to get feedback from practices on, the burden of the tools used to be able to track those patient-reported outcomes. What is the cost for you as a practice or a provider? And what is the additional burden to being able to report those? CMS also is talking about doing a survey mode expansion for CAPS for MIPS. And why this is relevant, because I know a lot of people right now don't necessarily use CAPS for MIPS, but this measure is built into almost all of the MVPs that we have so far. And this is a reporting option that you can use as one of your 4 measures. So being able to expand the survey mode, going from mail and phone to expanding to also starting out with web-based contact first, would be able to get you more beneficiaries attributed to being able to actually get scored on that survey. So CMS is wanting to get some feedback on what is the burden of being able to implement CAPS for MIPS, and then also really what's the feasibility as a practice, as a provider, to being able to collect and report emails for those beneficiaries. And then Vicki, do you want to cover that last one on promoting interoperability?
Yeah, so we did talk about live by 2025. So making sure that, is this possible? Start planning with your KHI representative to get that moving. And also, are there opportunities to further advance core objectives around that timeliness, quality data exchange? And also, are there opportunities for the Medicare promoting interoperability performance category to better incentivize the adoption of more advanced information exchange standards and mechanisms to help with those extra costs of implementing these extra public health registries?
All righty, so now we are finally at our top 10. And again, these are in no particular order, so I'll kind of start out first. I think one of the top impacts from this are our 75s on the list. So data completeness is being held through 2028 at 75%, but CMS is giving every indication that that could increase starting with 2029, when it sounds like there's a lot of other stuff that could be happening in 2029 as well. Especially, this is important if you are using a registry, if you are using a QCDR, making sure that you have all of that patient population built into your denominator. And then finally, the other 75, number 7 on the list, is maintaining that performance threshold at least through 2025. We might see it increase in future, we'll likely see it increase in future performance years. And whoever else wants to go next, give me your top 2.
Okay, I'll go. So I'll start here with the very first one, that data submission and removal criteria for all categories. Their CMS is proposing to adopt those minimum criteria for qualifying data submissions for MIPS performance for the quality improvement activity and PI categories. And that's really to help eliminate unintended data submissions. So they want to make sure that you complete everything so that they understand that that is an actual intended submission. So with quality, make sure you have to include that numerator denominator for at least one quality measure. Improvement activities, you have to include a yes for at least one activity. And then your PI has to include all of those requirements for reporting for data on all your measures, the cert ID, your start and end dates, and then those attestation statements. So that's what's going on with that. And then the last one that I'll talk about is that number 10. So we'll talk about new cost measures. They have the 6 new cost measures to be on the lookout for. Look at those measure specs to see if they will could apply to your organization. And then also that updated benchmarking methodology they're using that standard deviation and that median on that performance threshold to determine that upcoming. So those are my 2 things. I'll let somebody go next.
I'll go. My top 2, the first one is number 3, removal of 24/7 access to medical records. This has become common practice for most organizations, especially since the pandemic. It's a huge benefit for their patients. It's widely used among our practices as an improvement activity. So this could be an impact for 2025 submission and choosing an activity that aligns more along the line of the scope of your practice. So, but also, it can be it can have some cons to it also, by staff shortages, not being able to cover those extended hours. So you kind of have to rate the pros and cons of this activity to see if this is something that you would love to continue, which would be great in commenting to CMS about how important this activity is to your practice, or something, or start looking at the inventory and looking at some other activities that would also align with your practice so you can attest to in 2025. And then my other impact is number 8, which is topped-out measure benchmarks for specialists. Right now, that looks to impact our eligible clinicians who submit for an MVP or a specialty set. So depending on your performance, how you do in your performance, you can score the full 10 points. So that can be pretty impactful for anybody that is submitting for an MVP and a specialty set.
So I'll go ahead and do mine here. I'll start with this number 5. With all the work that CMS is doing around improvement activities category, they're really reducing the burden on our clinicians, especially removing weights and the number of activities they need to do, but really do anticipate them cleaning out that inventory and start to removing quite a few measures, and choices will become very limited. And my second one here is the high number of RFIs, that number 9 on this list. We've talked about it a lot in this webinar, but CMS is really seeking feedback across a lot of areas, MVPs, quality, and PI specifically. So if you do feel strongly, please give your feedback back to CMS and really have your points considered.
And I'll finish us out on our last 2 key impacts. So for number 4, updated SAFER guides. CMS had recently finalized that you had to attest yes to having completed the high priority SAFER guide in the 2024 final rule. So this year we had a lot of practices that completed that guide for the first time, and they would have been able to just do a review next year and apply those updates. If this is finalized, the upcoming SAFER guide updates would require you to do a full completion of that guide again, and it would prevent that simple review. So that is something to keep on your radar. And the last one is number 6, there being no new ECQMs proposed. So if your practice reports ECQMs, consider exploring your options with those other collection types and determine if your EMR can function as a registry, or if they have plans to complete the self-nomination process and try to become a registry in the future. Just asking those questions. Being proactive is going to be essential in planning for future participation in the quality payment program. So just my advice is to just be proactive and plan ahead.
Thank you all so much for your insights into our impacts. I think it's becoming clear that, there's a lot of different changes that are coming down the pike. 2023 was the first year that we actually had folks submitting for MVPs. We've talked about MVPs for a long time. And so I do think that over the next year or two, we are going to see a lot of shakeup and a lot of changes for the program as well. So real quick, just wanted to advertise some of our upcoming webinars. We do have over September and October are going to be some client only webinars that we will have. You should have those calendar invites on your calendar to join us. We're also going to have our year-end review in November, and then we will also have some attestation prep documents and a mini video going out to everyone as well, so that you can get prepared for your 2024, hard to believe we're talking about that, 2024 attestation. And then I want to leave you all with our annual conference. If you haven't already done so, we would love to see you there or to see you online at our Innovating for Better Health Outcomes. It's going to be held on Thursday, October 24th at the Campbell House here in Lexington. You can scan that QR code, or you can go to our event website and register. Again, we would love to see you there, and please register as soon as possible. And let us know if you do have any questions about it. I don't see any questions in our chat for today, but if you have anything after you've digested this a little bit, please reach out to your advisor. We are happy to help answer any of those questions for you. And so again, thank you for joining our jam-packed proposed rule webinar for calendar year 2025. You all have a wonderful day, and thank you so much.